Okay, we're going to talk about chapter 34, and that is going to be the pain management, and that to it is chapter 34 in your Perry and Potter. So before we can really start talking about pain, I just want to put out there that pain is very individualized, pain is very subjective. If the patient tells you they're having pain, they're having pain. And so there are a select few patients that aren't going to be able to maybe express their pain. So think about your infants. Think about your elderly patients that have dementia. Think about your unconscious patients. Think about your patients that have, maybe they have paralysis and they can't really tell you where their pain is. So for us, if our patients are alert and oriented and can tell us about their pain, we can understand that pain. But for those patients that can't do that, it's going to be very important that we do a very careful assessment and make sure that we're catching all of our pain responses on our patients and that we deal with their pain. So really, to know pain, we need to understand pain. So how does pain work, and how can we make pain better for our patients? So there's 4 specific physiological processes that are going to happen when you get a painful stimuli. 1 is transduction, 2 is transmission, then you're going to have perception and modulation. So basically, transduction is when we get the pain response. It's either thermal, mechanical, or chemical. It's going to be one of those 3 that injury is going to release a stimuli that's going to cause pain. That pain is going to send an electrical impulse through your peripheral nerve fibers. Those peripheral nerve fibers are called nociceptors, and they're going to send that through your peripheral nerve fiber. So that's going to be through the periphery of the body. That's your peripheral nervous system, the PNS. Then it's going to send it through transmission along nerve fibers. And inside those nerve fibers, we have little neurotransmitters that are going to transmit that signal of pain. And those transmission is going to be, it's going to like, when cellular damage occurs, or when you get that damage that occurs through whatever thermal, mechanical, or whatever means of cellular damage that you have, it's going to release these neurotransmitters. These neurotransmitters is like prostaglandins, histamines, bradykinins, and substance P. These pain sensitizing substances are going to kind of like surround your pain fibers, and it's going to spread that message, causing an inflammatory response. Remember talking about the inflammatory response back in the last chapter? All of these things these neurotransmitters are going to cause that inflammatory response. We're going to talk more about these here in just a minute. So they're going to transmit that using these neurotransmitters to travel that nerve impulse to travel along that nerve fiber. Then it's going to go into what we call perception. That's when your central nervous system is going to extract that information from that pain response. Your brain is going to interpret it. So it's not just one specific area in the brain that's going to interpret a pain response. It goes to the hypothalamus first, and then it kind of goes out to all of the brain. And the brain is going to kind of interpret that to where is that pain response at, how long has it been going on, and how bad is it. So it's going to interpret it for you. And so that's where it's going to start. Then it's going to go to modulation. And modulation is going to happen when those neurotransmitters cause the body or us to move away from that painful stimuli. So that's a protective response. It's modulated by these pain responses in the body. And these are, remember we talked about the ones that are excitatory neurotransmitters. These are going to be the ones that are going to modulate and try to help us with our pain. And our body produces those too. Those are like serotonin and endorphins. So our body automatically produces those for us and helps control our pain through those neurotransmitters. So thinking about that, we're going to think about the pain response. So I want you to know, I can't get my face to go where I want you to see it. These are substances that our bodies automatically produce that either help with that pain response, or they try to control the pain response. So there's certain neurotransmitters that are going to increase that pain transmission and cause that inflammatory response. So if you have a crushing injury, your body's going to respond by doing that inflammatory process like we talked about before. You're going to get pain, you're going to get inflammation, you're going to get redness, you're going to get edema, you might get warmth to the area, and that's what's going to cause that. These are substance P, prostaglandins that your body produces, bradykinin, and histamine. So if we have a patient that has an allergic response to something, they're going to get itching of the skin, they're going to get redness and swelling at the site of maybe where their allergy is, and that is because of the histamines that are being released inside of the body as a response to whatever entered their body. And then there's substances that decrease our pain. So they kind of produce an analgesic effect for us. That is serotonin and endorphins. So if you think about serotonin, it's kind of in the brain, it releases and kind of helps give you that analgesic effect. When you think about endorphins, that's what, like, people who run or people who do certain things have endorphins that are released that help with those pain responses. So thinking about how we can help someone's pain response without pharmacological measures. So one of the ways that they think about it is a gate control theory. So if you think about the gate control, think of a big gate that opens and closes according to what's going through it. So when you think about the central nervous system, how can we block that going to the brain to help with that pain response? So as pain passes through that gate, the pain is severe, it's bad, it's uncontrollable. But if we can shut that gate, we can help that pain response. Maybe we can't shut it all the way, but we can shut it some. So the theory is that if we can use certain non-pharmacological measures to help with some of that pain relief, that will help. So when you think about if you have a sprained ankle, we put cold on it initially, and that cold decreases that inflammatory response, therefore decreases the pain. Then we turn to heat. That brings more things, brings more blood, brings more clotting factors, brings more white blood cells to help heal to that area. So that's what we mean by closing that gate. So some people feel that massage helps with that. Imagery, where you think about, you're having severe pain, let's think about something good. Think of yourself laying on the beach and, the sun shining on your face or something like that. That's what they're talking about with that. And then a TENS unit. Sometimes people will have TENS unit where they put it on a specific area of their body and it shoots little electrical impulses through there, and the goal is to help close that gate to help with the pain. So that's what they're talking about with physiological of pain. So that's the gate control theory. I would know the gate control theory. It's kind of important to understand that gate control theory. So then our physiological responses. So in your body, when you have physiological responses that are happening to pain, if we have low to moderate intensity pain or superficial pain, the sympathetic nervous system is stimulated. So we have a sympathetic nervous system and we have a parasympathetic nervous system. The sympathetic nervous system is, we kind of call that like the fight or flight. So if you are working someplace and you put your hand on a hot iron, you're immediately going to get that sympathetic stimulation because it's like fight or flight. I'm going to pull my hand back because that was hot. That was intensity of the pain. It was superficial pain. I'm going to pull it back. Where if we have severe or deep pain, that is when that parasympathetic stimulation is going to occur. If parasympathetic stimulation, or it goes on for long periods of time, that parasympathetic is constantly being out and out and out. If we don't treat the pain accordingly, we don't treat it good, it can cause, and it can go into what we call chronic pain. And chronic pain is harder to treat. And we feel like chronic pain is where it's been pain that has been unrelieved, and people have that chronic everyday pain. It's relenting, it never goes away. It can actually cause permanent neuroplastic changes in the brain where our body has a very difficult time understanding the pain, and it can cause permanent damage in the brain where the brain can't go back to where it once was. So, that's what we worry about with chronic pain, is getting those neuroplastic changes, and then they, contribute to that chronic pain syndromes, and they can't really get that pain to go away. So we don't want those neuroplastic changes to occur. So we want to make sure that we're treating their pain accordingly so we don't get those brain changes. Behavioral responses: if you see somebody gritting their teeth, they got facial grimacing, they're holding or guarding a painful area. Let's say that, you got somebody that has a broken arm and, they're guarding that arm. They don't want you to touch it. So always be looking for those cues, because in certain cultures, it is considered, not good if they tell you they're having pain, or they express pain. So there's certain cultures that don't do that. So it's being aware of different cultures and making sure we're looking for those behavioral responses. That way we know and we're treating their pain and not allowing it to get out of hand. So different types of pain that people have. One is acute and transient pain. These are important to know the differences. So acute pain is considered protective. We usually can identify where the source came from, and it usually has a short duration. So that would be like a broken arm. That would be like a burn. That would be falling and having a crushing injury. So the sympathetic nervous system is going to be stimulated. Our vital signs are going to go up. Our blood pressure is going to go up. Our pulse is going to go up. Our respirations are going to go up. So we're going to see those vital signs change. That's acute and transient. It's protective, and it's usually short. Where chronic or persistent, that is non-cancerous. Cancer pain's a little bit different, but this is non-protective. It may not have an identifiable cause. Maybe this is somebody that has fibromyalgia and they talk about pain all over the body. Somebody that has rheumatoid arthritis and it's chronic all over the body. This is pain that lasts longer than 6 months. Someone that has chronic pain like that, their vital signs may not be altered. So a lot of times as nurses, we're like, well, they're not having pain because their vital signs are all fine. That doesn't necessarily mean that they're not having pain. Sometimes patients have just adjusted to that chronic pain and the vital signs haven't changed. So be aware of that when you're doing your assessment. So there's subtypes of pain. So thinking about, I want to make sure I didn't skip anything. Subtypes of pain, we got cancer pain, idiopathic pain, referred pain, and intractable pain. So cancer pain can be acute or chronic. It's nociceptive, or it can be neuropathic. We'll talk about those here in just a minute and what the difference in those two are. So as that tumor progresses, the pain can be increased. So cancer is like, we're going to talk about cancer later on in fundamentals, but cancer actually invades tissues, invades nerves, invades blood cells. So as that tumor invades more spaces, it increases pain, because it's getting into those nerves that have pain-producing stimuli that are going to the brain. So this can be acute, chronic, and it can be nociceptive or neuropathic, and we'll talk about that. Idiopathic pain just means that it's pain, but we don't have a cause, and it's kind of seen as excessive. So it's chronic pain without cause or seen as excessive. So, just think about that. Idiopathic pain, and it's idiopathic means unknown. We don't really know what the cause is. So think about referred pain. Referred pain is where you might be having an appendicitis, and you've got an appendicitis, but the pain may be up in, your pain should be in the lower right quadrant, but you're having epigastric pain. That's where what happens sometimes inside our organs, we have pain, and the body knows it's having pain, and it sent all those stimuli to the brain, but when the brain interprets it, it doesn't send it back to the right place because it can't find the correct location. Over time, as the brain continues to receive that signal, it may be able to identify where it's at, but referred pain is just where it goes someplace else. I'm not sure if it'll be talked about later on, but I want you to know about phantom pain. Phantom pain is where you have a patient that maybe has an amputation, and their leg's been amputated, and they're like, but I'm having pain in my big toe on the leg that's been amputated. That can happen because the brain still interprets that there might be a limb there, and so it's still sending signals. Over time, that phantom pain will go away, but it is something that can be there for your patients, especially newly amputated patients. Intractable pain. This is pain that cannot be controlled by standard medical treatment. So this is pain that happens, and with using all the interventions that we have, we're really unable to get their pain under control. Then I'm going to talk about the types of pain. So remember when I talked about up here, I talked about the cancer pain. So now we're going to talk about the two types of pain. We're going to talk about that nociceptive pain, and we're going to talk about neuropathic pain. So you will need to know these. So nociceptive pain is when there's damage or inflammation to tissue. So this is going to be tissue, and we're going to break it down into different types of tissue. This pain is usually throbbing, aching, and localized. So you got three types of tissue. You got your somatic tissue, that's going to be your bones, joints, muscles, and connective tissue. Or your visceral. Visceral means internal organs. This is where you're going to get that referred pain. Cutaneous is on the skin. So this is where you have a patient that maybe they have an infected finger. It's on the skin. I can see it. It's throbbing. It's aching. I have the inflammatory response right there. That's nociceptive. That's throbbing, aching, localized under somatic, visceral, and cutaneous. Somatic is just your bones, your joints, your muscles. Then we're going to go to neuropathic. If you break that down, patho means disease, neuro means nerve. So we have a disease of the nerve. So this is different. This is where we got abnormal damage to pain nerves. This includes your phantom pain. This is your pain from your amputees and things like that. This pain is usually very intense. It feels like pins and needles, or it feels like something is shooting up a nerve. It shoots up that nerve, and it feels like it's burning all the way up a leg. So this is what these patients are going to refer to with this neuropathic pain. It's going to be a different pain response. So we treat these differently than we're going to treat the nociceptive pain. So neuropathic pain, a lot of times we use antidepressants to help treat those. We use antidepressants such as like Lexapro, Prozac, any of those type of things. And then we use antispasmodics to help with those spasms in the nerves, and we use muscle relaxers. So those are the types of medications that we would use to help with those pains. Okay. Ooh. So what are some things that are going to affect pain in an individual? Age. So you're very young, don't understand pain very well. Your infants don't know what pain, they know they're having something, but they don't know what it is. Your young children they don't really have any life experience with pain, so it's going to be hard for them to understand pain. And then as they get older, they will have experiences with pain. Your dementia patients that are older, they don't really know how to express their pain to you because they've lost that ability to do that. Peripheral vascular disease, they don't feel that pain anymore. So a lot of factors are going to experience that. Fatigue. The more fatigue a patient is, the more intensified that pain response is. So if you get a patient that isn't sleeping, their nutrition is poor, they're not feeling good, their pain, that's going to increase their pain experience and make it worse. Genetic sensitivities. Some people are more genetically prone to having, a higher pain tolerance. You've seen those patients that have lots and lots of pain and they don't feel it. So there's genetic things that kind of predispose us to how we're going to deal with pain. Cognitive functioning. Again, we're going back to our dementia patients, but if you've got a patient that cognitively isn't able to identify or know what pain is, we have to be able to use our assessment skills to understand that they're having pain. Think about maybe your 25-year-old patient that has severe cerebral palsy, that is nonverbal. What can we look for that patient's having pain? Prior experiences with pain. If you've had pain before and you've experienced pain before, you have experience with pain. But that 5-year-old that you're taking care of doesn't have any prior experiences with pain. Maybe you've got a 40-year-old patient that's never really had any pain, and all of a sudden they have a crushing injury, and now they don't have many prior experiences to go off of. Anxiety and fear. When people have pain, it produces anxiety, it produces fear because they don't understand the pain, they don't know why they're having the pain, they don't know why we can't help the pain, and that is anxiety provoking. And then support systems. It makes a big difference with our patients if they have good support systems at home, such as if they have a significant other, a spouse, they have good family support. Maybe they have a community that helps them. Maybe they have a church family. Maybe they have a work family. What support systems do they have in place that's going to help them? If you have a patient that has no one, that's going to affect their pain response. They may have a higher pain response because they have that anxiety and fear and don't have anybody helping them. So other risk factors, there are a certain percentage of people that are undertreated. We undertreat their pain. So think about societal and cultural attitudes. A lot of times, cultures don't really want to present with pain. So we got to make sure that we are aware of all the different cultural things out there, societal attitudes. A lot of people and nurses are guilty. We have patients that come in and they're complaining of severe pain, and they're like, nah, they cannot be in that much pain because they're sleeping. They can't be in that much pain because of this. They're just drug seeking. They're just this. They're just that. So we have to get our mindsets away from that. And if our patient says they have pain, pain exists. Now, again, you go back to that chronic pain, you might not see that change in those vital signs. So we're going to have to look at our patients. We're going to have to assess our patients. If you got a patient that's sleeping and they're grimacing in their sleep, or they're, clenching their teeth in their sleep, they're probably having pain. Their body's just adapted to that pain. And then lack of knowledge. A lot of times we just lack the knowledge to understand pain. Pain is very individualized. A lot of patients aren't going to take pain medications. We can offer it to them. We can give that to them. But many of our elderly patients will take those medications home and they will put them in the cabinet and they won't take them because they're afraid they're going to get addicted. So we need to talk to them about that. How can we help you with your pain if you don't take your medication? So we can discuss them about, addiction, that if you've just had a surgical procedure, you need to take your pain medication for those first few days to help you manage that pain. So when you go home, you can take other medications that will help manage that pain. Fear of respiratory depression. A lot of patients, especially your elderly patients, are very afraid to take any kind of medication that might depress that central nervous system because they're afraid they're not going to wake up. They're afraid they're not going to breathe. So make sure that you are talking to your patients about those things and help them understand pain and how we treat that pain. Other risk factors, certain patients are undertreated, and we've already talked about that. Your infants may be having pain, especially infants that have been circumcised. Maybe you got an infant that has a bellyache, and we don't know that they're having pain, so we have to really do our assessment skills. Is the infant unconsolable? Is the infant put in the fetal position, constantly going to the fetal position? Are they crying? Are you able to console them? There's lots of things that we have, cues that we have to look for our infants. We have to look for that for our children. A lot of times you ask a child if they're in pain, they don't know what that word means. They don't know what a scale to 1 to 10 means. So we give them a different pain scale to go from because they don't understand what hurts. So sometimes you will say, where's your boo-boo? Where does it throb at? Where does it feel like you hear a heartbeat or feel a heartbeat? Sometimes you have to go at it at a different way. Older patients, because a lot of times your older patients just won't tell you because of all those things: fear of addiction, fear of not, of not waking up, and then our substance abuse patients. So we get patients that are addicted to medications. We don't want to give them more medications to increase their addiction, but the only way to get them off their addiction is to give them medications. So it's kind of a vicious cycle for our substance abuse patients, especially if they come in and you've got a patient coming off alcohol and their body is hurting all over. We have to give them certain medications to help with that. We get a patient that comes in and they're coming off meth, or we've got to give them something that's going to help with that pain response. So the causes of acute and chronic pain. So if you think of the causes, trauma. If your patient has been in a motor vehicle accident, they have been hit by a car, they have had a motorcycle accident, whatever the cause, that can be acute and chronic pain. Surgery is going to be acute pain that could turn into chronic. Cancer can be acute or chronic. Arthritis can be the same thing. Fibromyalgia, neuropathy, all of those can be chronic pains, but they could also be acute pain. Sometimes patients that have fibromyalgia can get it under control, and then all of a sudden it comes back again. Your patients that have sickle cell anemia, that can have acute and chronic pain. Diagnostic or treatment procedures. Nothing that we do in the hospital is pain-free. I mean, anytime we do a diagnostic procedure, we're going to give you IVs. We're going to give you certain things for that treatment or that procedure that could be painful. So we got to think about all that and treating that pain in our patients. So when you think about it, we have 4 things that we always think about when we're trying to critically think with our patients. We think about knowledge, experience, attitudes, and standards. So if you think about knowledge, go back to your 4 physiological things: transduction, modulation, transmission. Go back to those and understand how pain is perceived and what disease process are we dealing with our patient. What is the communication? What kind of communication do we have with our patients? We know if we have better communication with our patients are going to fare better. And what pain therapies are they doing? What things do we know help with pain? And then what experience do you have with pain? Have you been taking care of patients in the ICU that have lots of experience with pain? Have you been taking care of patients in the PACU where they're going to come out of surgery and have severe pain? Have you been in an ER where you see patients come in at their worst? So what experience do you have to bring to the table? Maybe you've experienced pain and you can relate to some of these patients. Maybe you have family members that experience pain and relate. Attitudes. What is your attitude towards pain? What is our responsibility towards pain? And then standards. Many times our doctors don't just treat our patients because of, the doctor, he knows everything. No, the doctors don't know everything. Many times doctors are guided by lots of different journals that are out there, lots of different evidence-based studies. So we do evidence-based studies using these medications. What medications through these studies have proven to be best for surgical pain? What medications through these studies are proven to be best for severe trauma? Or what studies have been best for whatever the reason is. So all those physicians and nurses are guided by all of that. The Oncological Society comes up with standards to help treat cancer pain. So the doctors know by these studies that we can treat cancer using these things, and it has been shown to give benefit. Now, there's different studies for different types of cancer that we would look at to determine which one would be the best for our patients. So thinking about the nursing process, always go back to the nursing process. What is that? ADPI, assessment, diagnosis or focus, plan, intervention, and evaluation. So we're going to talk about those. So determine the level of pain helps us know what level your patient can function at. So when your patient's in acute pain, Are they going to be able to go to their job? Are they going to be able to listen? Are they going to be able to do what needs to be done? So once we get our patient more comfortable, then we can look at that assessment data. So I want you to think of an acronym, PQRSTU. So pain is always changing. So monitor it on a regular basis. It kind of is our fifth vital sign. So we do temperature, pulse, respiration, blood pressure, pain, pulse oximetry. So those are things that should go along with every assessment that you do. Are you having pain? Where is your pain? How, on a scale from 1 to 10, what is your pain? Where does your pain radiate? Where does your pain go? So looking at that, we're going to look at our assessment. So we're going to look at, our different patients and how they express pain. Not everybody's going to volunteer that they're in pain, so we have to always ask if they're in pain. Recognize those nonverbal cues and those expressions, like we talked about, the clenching of the fist, the facial grimacing, moaning, guarding of a certain area, and then patients that are unable to self-report pain, which we've talked about that already. Our infants, our children, our dementia patients, maybe our patients that are aphasic, that's had a stroke and they're not able to talk, our critically ill or unconscious patients. So we're going to look at the characteristics of pain. So this is where the PQRST comes into effect. So timing, when did it start? How long does it last? And does it have a pattern that you can see? Yes, it usually starts in the morning and it usually lasts till lunchtime. And it what makes it worse is if I get up and walk around and it's a throbbing type pain. But it does help if I sit down and I raise my leg up. So those are kinds of things that you're going to look at. So thinking of our PQRST. So P, palliative or provocative. So what makes it better and what makes it worse. Palliative is what makes it better. Provocative is what makes it worse. So that can be your P. And then your Q is, how do you describe the pain? Tell me what that pain feels like. Is it the pins and needles? Is it the throbby, achy pain? Is it nociceptive or is it neuropathic? So know the difference. Relief measures. What makes the pain better? And then the S is severity. Scale to 1 to 10, where are you at? Timing. That's your onset, duration, and your pattern. Is it constant? Is it intermittent? Is it both? And then U. This is the big one. How does that pain affect you? Because there are many people that have chronic pain that can't live their lives the way they want to because of the pain. So it's very important that when we're doing our assessment, what can we do to help that patient do the things that they enjoy doing? You probably all know a patient that has had to stop doing something that they enjoyed because it causes pain now. So what can we do to help with that? So thinking about that, here is we use our scale from 1 to 5. So this would be like our kids. So our adults, we're going to use 1 to 5 and a pain rating scale. This would be for like our kids. No hurt, the worst hurt. So that way we can kind of ask it, point to which one is you today. And sometimes that can help and it gives us an idea of where they're at. Now, whatever pain scale you use the same pain scale for everyone. So whatever the first person uses as their pain scale, we want to use the same pain scale or we're going to get different views on pain. So we could use this for our kids, we could use this for our dementia patients, we could use this for all of those patients. So we're still assessing. So what are concomitant symptoms that go along with it? Concomitant just means what are other symptoms that go with pain? If you've ever had severe pain, did you get sick at your stomach? Did you throw up? Did it give you a headache? All of those are things that go along with your pain. Somebody that gets a migraine, a lot of times nausea, vomiting goes along with that. Sometimes if somebody has acute pain in their leg and it's hurting really bad, they will throw up. They will have nausea. Those are concomitant symptoms that go with that we would need to treat also. And then what is our patient's expectation? What is their expectation of us to relieve their pain? So, do you have a patient that their pain is a 10? Do they expect their pain to be a 0? What is your patient's expectations on their pain? And then how quickly did we try to relieve their pain? You know, there's nothing worse than a patient being in pain and wait 2 hours to get their pain medication. So SIH has something that they've started, an initiative to make sure we're treating our patient's pain appropriately, that if you give pain medication, within 30 to 45 minutes, you have to go back and reassess and redocument in the chart that you have assessed that pain. So if you don't do that, SIH will ding you on that on your evaluations because you were not timely on getting back with your patients. And then documentation. You're going to document that you're going to give the report of pain. You're going to document that you've given the medications for the pain. You're going to document what you did for their pain. I repositioned them. I supported them with pillows. I lowered the head of the bed. I increased the head of the bed. Whatever that you did to help with that pain. So again, always use that same assessment tool with each patient. So nursing diagnosis or focus. So we're going to look at our patient. Any patient that we have could have any of these nursing diagnoses or focuses. So we choose one that is with our patient that what they need at the moment. So ineffective coping could be a patient that is not coping well with their pain. This could be our chronically fatigued patient. Impaired mobility, that could be our patients that have had surgery, a hip replacement. Dressing self-care deficit, maybe that's a patient that has broken their shoulder or they've had shoulder surgery and they can't dress themselves. Anxiety, fear, social isolation, they can't get out anymore because they've broken their leg and now they're at home in a wheelchair and they can't go do the things that they usually did. So all of those things we're going to have to identify. And then goals or outcomes. This is our planning phase. So the planning phase is usually where we're going to set our goals. And how are we going to set those goals? The goals need to be identifiable, they need to be measurable, and they need to be realistic. You cannot give a goal of a paraplegic that the patient's going to walk within 4 weeks. It's unrealistic that that's going to happen. So you have to set your goals to the level of what their function is. What is their function and what goal are you going to be doing? Consider what kind of pain, how it affects their function, and then who's involved in helping that patient. You know, where's that support system that we talked about? Where's their friends, family, specialist, you know, documentation, who's going to be involved in the care of that patient. Now we're going to implement. So this is the I's. This is where we get to go do our stuff now. So it depends on the nature of the pain and the extent of the effect of what pain relief therapy are we going to give our patient. So what pain relief therapies have we chosen to do? So what other pain relief measures have worked or what other pain relief measures didn't work? So why try the ones that didn't work again? Let's go to the ones that worked. Let's try those. So we're always going to start with the least invasive and the safest one first. So let's start with something that we can do. Let's start with those gait control theories. Let's start with those non-pharmacologicals, moving them, pillow propping, wedges, massages, hot, cold, all of those pain relief measures that we can do without using pharmacological measures first. Now, can a CNA or can they document or screen for pain? Yes, a nurse-assisted personnel can screen for pain, but once pain has been identified, it is the nurse's responsibility to treat the pain and then go back and look at the pain and go back and reassess. So the nursing assistant or the nurse-assisted personnel can screen for pain. They can ask. But if there's pain, it is the nurse's responsibility to go assess the patient, document medications, and then document their response to that pain. Health promotion is just, when you talk about health promotion, this is where we talk about keeping patients healthy. And we've talked about that previously in our other chapters. It's about keeping patients healthy because once they get sick, now it's going to be more costly. It's going to be more time in the hospital. It's going to be more invasive. So if we can maintain the health of our patients and maintain the life that they want to live, it will help them in the long run to lead better lives. So these are just going to be some of your non-pharmacological pain relief measures. These are going to be your gait control kind of things. One thing that we always want to do is provide our patients with anticipatory guidance. What does that mean? Well, it kind of means what it says. We're going to guide them through a procedure before we do the procedure. So if you're going to start an IV, tell them, I'm going to start an IV. This is what I'm going to do. Yes, there's going to be a little pain with that initial stick, but I'm going to do my best to keep it as pain-free as I can. It won't be pain-free, but I'm going to give them anticipatory guidance to let them know what's going to happen. Okay, you're going to be going down for this procedure. Yes, it's going to hurt initially when they put the IV in, but once they get the IV in and the medication goes in, your pain should be better. So that's anticipatory guidance, letting them know what you're going to do before you do it. And then distraction. What can we help getting them distracted? We do have distraction cards up on units, and sometimes it has like coloring books, cards, Uno, things in it that can help them get their mind off of things. Cutaneous stimulation, we've talked about that. That is your cold, hot, massage, TINS, imagery, thinking of different things, acupuncture, using pillows, using props, using things that can help with your patients with their pain. All of that is non-pharmacological. Now, going to acute care, we're going to talk about pharmacological pain therapies. This is going to be your analgesics, your PCA pumps, your paraneural local anesthetic infusions. It's going to help with the pain at the spinal cord level, local anesthetics, and epidural analgesics. So talking about those, if we do a paraneural local anesthetic infusion, this is where we're going to put a catheter from a surgical wound. We're going to place it near a nerve or a group of nerves that connects to a pump that contains a local anesthetic. So it's a paraneural local anesthetic infusion that goes into a specific spot. We usually leave that in for like 48 hours. It's continuous or it can be on demand. That might be somebody who's having a surgical procedure and we're going to put that into that surgical wound to block that nerves to help with some of that pain. So local anesthetics. Local anesthetics is going to be loss of sensation of a localized part. So that might be I'm going to remove something on my hand and I'm going to inject a local area. So we usually use lidocaine or something similar, and we're going to apply it either topical. We can give it sub-Q, which is under the subcutaneous. We can give it paraneurally, so that's going to be around the nerve, or we can give it intradermally. So we can give this everywhere. So this would be like when you're going to get a tooth filled, and they go in and they're going to localize that area. You get a mole removed, and they're going to localize that area. Then we go to epidurals. These are what we call regional anesthesia. These are going to block that transmission of pain at the spinal cord level. These are short or long-term therapies, and we usually put it in with a needle, and then we thread a catheter through, and that catheter can stay in place for short-term, or it can stay in place for longer-term. And the biggest thing with epidurals is hypotension. Sometimes when we start an epidural, the patient will have a hypotensive episode, so sometimes we'll have to actually give them a little bit extra fluids to get through that, but it's usually going to block a region from wherever it is in the spinal cord. So if it's here in the spinal cord, we're going to block everything from there down. So if they were having surgery on their knee, we might give them an epidural, or we might give them a spinal block, and that would help with the pain all the way from wherever that is all the way down, and they wouldn't feel anything. So non-opioid analgesics. So let's talk about non-opioids. These are things that they're not going to get addicted to. Acetaminophen, NSAIDs. NSAIDs just stand for non-steroidals anti-inflammatory anti-inflammatory drugs. And this is like Aleve,
aspirin, anything like that. Those are all NSAIDs. Ibuprofen, all of that kind of stuff is considered NSAIDs. Be careful with some of your drugs because they do cause hepatotoxic, that causes toxicity to the liver. So talking about, when you talk about the hepatitis, if we give Tylenol too much, that can hurt their liver and in turn cause them to go into some liver disease. So no one should receive any more than 4 grams of Tylenol per day. So if you're taking extra strength Tylenol, 1,000 milligrams, you can only take that 4 times a day. So that would be every 6 hours of 1,000 milligrams, because 4 would be max. Monitor for salicylism, which means that salicylates are aspirin. You can get toxicity from your salicylates, and it can cause tinnitus, which is ringing in the ear, vertigo, which is dizziness, and decreased hearing acuity. So we want to monitor those aspirins very close. And if your patients start complaining of ringing in their ears, we're going to have to back off on those aspirins. But we do know aspirin helps really well with certain types of pains. Prevent gastric upset. So a lot of your aspirin, your ibuprofens cause a lot of pain in the stomach. So we want them to take it with food, or they can take it with an antacid. So we want them to take it with put something in their stomach before they eat it. Also, there's bleeding tendencies with your NSAIDs. There is a bleeding tendency with that, so we got to monitor our bleeding on patients that are taking these non-steroidals for long periods of time. So if you get a patient that's coming in to have surgery, a lot of times they will have you stop all of their NSAIDs several days prior. If they're getting fecal for occult blood testing, we're screening for rectal cancer, and we're doing the fecal for occult blood, we'll have to have them stop that for a few days prior to the testing, just because there can be some microscopic bleeding from those NSAID usage. Okay, so opioids. Here's the big thing about opioids. They cause sedation, so we're going to have to monitor that level of consciousness. It also causes respiratory depression, so we're going to have to monitor our respiratory rate. So if we got a patient and their respirations go below 12, that's going to be a problem for us. Orthostatic hypotension, so we got to make sure we're with that patient when we stand them up for the first time, because it can cause that decrease in that blood pressure and they can pass out on you. We do know that opioids causes urinary retention. So if you got a patient that's getting opioids, your patient should void once a shift if they don't have a catheter. So if it's, you come on at 7 o'clock in the morning and it's, 2 o'clock and your patient hasn't voided, we better be looking for some bladder distension. So I&O is going to be very important. Make sure we're doing I&O, make sure we're getting that output and that they're going to the bathroom. They will cause nausea and vomiting, so sometimes we have to give other medications along with the opioids to help, counterbalance the nausea and vomiting that goes along with it. These also cause constipation, so we want them to drink plenty of fluids, take plenty of fibers, get up and walk around. Make sure that they're getting that ambulation. So patients with cancer. Patients with cancer is a little bit harder to deal with because sometimes your patients can have cancer pain that's intractable and really, really hard to treat. So it can be very debilitating for your patients. So there's certain guidelines that we use to help treat that. But we give a lot of our cancer patients analgesics. We might use certain medications for breakthrough pain. They might have patches. They might have continuous morphine drips. So whatever the best choice is for your patient. So thinking about here, a lot of times, here's your freedom of pain. Sometimes we have to use opioids, plus we have to use adjunct medication to help with that. If it's persisting, we might have to use non-opioids, we might have to use opioids, and we might have to use adjunct medications. So there's certain things that we may have to get on top of each other. So they may be on an opioid, they may be on another type of analgesic, they may have an epidural, they may have multiple things that are on that patient to help with some of that intractable pain. So then we're going to get to restorative care. Restorative care just means getting the patient to the best functioning that we can get them to. It may not be what they want, but it's the best we can get them to with where they're at in their life. So we might have to do those opioid infusions. Palliative care. Palliative care is different than hospice. Hospice is if you have up to 3 to 6 months to live. So we'll get hospice involved. But hospice doesn't do anything, but they do pain control, position, things like that. But hospice is there for the dying patient, where palliative care is a little bit different. So you may have a patient, maybe you have that 35-year-old that has colon cancer that is spread and to the spinal cord, and they have a large tumor in their spinal cord that is causing severe pain and causing their legs to have numbness and tingling all the time. So hospice would not treat that, but palliative care would go in, and we're not going to cure their cancer. This is not a curative. This is a palliative. So we go in and we remove that tumor, not the whole thing, but we remove what we can that's pushing on the spinal cord. It doesn't treat it, but it makes their lives more livable and they can tolerate the pain more. So that's palliative care. Adjunct medications, remember we talked about those adjunct medications? So you go back up here to your cancer pain and they're talking about adjunct medications. So here's your adjunct analgesics that we can use. So a lot of times we'll use anticonvulsants. Gabapentin is one that we use a lot. It's called Neurontin, gabapentin, and that helps a lot with your nerve pain. So if you have a patient that has neuropathy, or your patient that has something that is neuropathic pain, your gabapentin will help. Anti-anxiety medication, so this would be like your diazepam. Anything that's going to help with that. Tricyclic antidepressants, we know that those work a lot with pain control. So amitriptyline, Elavil. Anesthetic, we might do an infusion of lidocaine into a space to try to help with some of that pain. Antihistamines that we're going to use is hydroxyzine. Benadryls, which Benadryls is, I can't think of the generic name of Benadryl off the top of my head. I hate being on the spot. Diphenhydramine is your Benadryl. So we can use those antihistamines to help with some of that. Glucocorticoids, so that's going to be your steroids. Steroids decrease the inflammation and help them to tolerate that pain a little bit better. But steroids also can cause some problems because steroids are going to mask a lot of your inflammatory responses. So we got to really use our assessment skills. Antiemetics, those are your patients that have nausea and vomiting. So we might use aldosterone, which is going to be an antiemetic that's going to help with that. PCA pump, that is your patient-controlled anesthesia, where we're going to give small little doses. That's going to be locked out. So we're going to give them small doses, lock it, small dose, lock it, small dose, lock it. Now the drugs that we use for that is usually morphine, hydrophone, and fentanyl. We use in those PCA pumps. I've seen Demerol in the PCA pumps, but make sure you talk to your patients that the only one that should be using that PCA pump is the patient. The patient is in charge of their pain. If the patient is in pain, they need to be instructed to push that PCA pump. If a parent or spouse or significant other or whoever is in that room, they are not to use the PCA pump. So if that patient is sleeping, that person in the room should not just push it and say, oh, we want to keep their pain down, so we'll push the button for them. It is the patient that pushes the button. No one should push the button but the patient. It is the patient's pain, not the person in the room. They don't know what their perception of pain is. So in interventions, if the pain is persistent, schedule pain interventions around the clock. So a lot of your doctors sometimes will give them medications around the clock. So every 4 hours, every 6 hours, they're going to get certain medications. It's easier to take a patient's pain down from a 5 to a 3 than it is to get a 10 to a 3. So if we schedule those medications around the clock, sometimes it's easier to keep pain under control. Make sure you review all your provider's prescriptions for analgesic. So make sure you're looking at all those prescriptions and kind of understand what they're supposed to do, what the side effects are, and how we're supposed to manage those. Older people, we've already talked about them being undertreated for pain. So make sure that we're talking to those elderly people about that. If you know your patient's going down for a very painful procedure, maybe they're going down for physical therapy and they've had a hip replacement, give them that medication prior to going to the procedure. So if you know that Sally's going down for some intense physical therapy at 9 o'clock, maybe you need to pre-medicate Sally about 9:15 to go down for her 10 o'clock therapy. So keep those things in mind. If maybe you need to do a dressing change and you know it's going to be really painful to do that dressing change, let's pre-medicate that person 30 minutes to an hour prior to that procedure. So then we know that we can get them pre-medicated. We had a little girl that had, when I worked in peds, she had like her whole torso, she was 3, her whole torso all the way down to her knees was burned. She had fell into a cauldron of burning soup and it burned her from here down. And so we knew that she was going down for debridement of that in the whirlpool. So we would pre-medicate her with morphine an hour before she went, so she was a little bit more calm prior to that, what we knew was going to be a painful procedure. So instruct your patients to report any developing of pain or recurrent pain. Don't wait till their pain is severe. It's easier to get that pain under control when it's at a 5 than it is at a 10. Okay, so evaluation, that's the last thing that you're going to do. So, you know, the patient is the person that we need to get the source of what their pain is. Don't ask significant others in the room. Don't ask somebody else standing around. The patient is the one that tells us how the interventions that we did worked. You know, compare what our actual outcome was and then what did the patient expect it to be. Did we meet their goal? Did we meet the goal that we set? And what was your patient's expectations? You know, assess their expectations. Did we meet those? Ask them lots of open-ended questions so they have to answer you with more verbalness than just yes or no. So that's important. Safety guidelines. So when we think about safety, this is our last one here, but think about safety guidelines and medications. Medications can be, it's probably the number one thing that new nurses make a mistake on. So it's very important that you be alert and really focused on giving your medications when you're giving medications. Make sure you're taking care of yourself. You need to come in thinking clearly and as critically as possible and make sure that you're healthy when you come into work. So when you go set up your medications, usually we have what we call a medication room. And the reason we do that is because we realize that a lot of our medication errors were occurring because nurses were trying to dispense medications or get medications and someone else is talking in their ear, and that's how you make medication errors. So we need the room to be in a distraction-free area so the nurse can go in and know what she needs to do at the time she needs to do it. So she needs to be in that quiet environment, that distraction-free environment to prepare all of her medications so she doesn't make that critical mistake. So those are just some very important concepts. Okay, so that is the end on pain. And I hope you've learned some things. You can go back and kind of look at these things. Make sure you take some notes.